Hello?
Back to you, Dr. Tang. Are you ready for the next session?
Yes.
You're on for how to optimize the implantation of mitral valve in valve.
Yes.
The floor is yours.
Thank you. So here's my disclosures, and I also want to acknowledge Dr. Papa for some of the slides presented here. So let's look at the re-op mitral valve surgery outcomes. These are the contemporary paper published a couple of years ago looking at re-op mitral valve surgery. And you can see here the 30-day mortality is still around 10%, stroke 2.8%, morbidity about 35%, and actually is also more expensive than primary mitral valve surgery. You can also see here, this is a paper from Emory comparing transcatheter mitral valve and valve replacement versus re-op mitral valve and valve replacement. There was no difference in outcomes, but the TMVR group were sicker, but at the same time have shorter ICU stay and hospital stay, less AFib, however, with slightly higher mitral gradient at 1 year. This was first presented at TCT. You can see here the 30-day mortality in early experience in mitral valve in valve is certainly not the best, but apparently is significantly improved. You can see from the Vivid registry versus 7 to 8% mortality in TVT registry presented before to actually only 3.3% in the mitral trial in a small series. In the US, the mitral valve in valve replacement has grown. You can see here last year, almost 900 cases have been performed. So this is an increasingly popular procedure in previous patients with previous mitral valve replacement. You can see here, in terms of transapical versus transeptal, most of them are now done transeptally, very few are transapically. So why do we do this? Well, it avoids the reoperation. And if this patient with previous CABG or aortic valve replacement, it's actually very difficult to expose the mitral valve. So it's certainly another attractive option. You don't have to remove the previous mitral valve. Sometimes it's very difficult because of the scar tissue set in, and also reduces the morbidity of open surgery and mortality. And of course, if you do it transeptally percutaneous, you can see the hemodynamic improvement right away, and most people can even go home the next day. Now, whether you do the re-op surgery, well, paravalvular leak, if you cannot do a percutaneous closure, you would need to likely reoperate to fix that. Certainly, endocarditis is a contraindication to valve in valve. If there's LVOT obstruction, you can certainly treat it percutaneously, like the septal ablation. I don't think you can do lampoon on a surgical mitral valve, but it may be possible. But certainly, the risk of LVOT obstruction is pretty low in these patients. And of course, if you do need to combine surgery like CABG or tricuspid repair or MACE, you should probably consider re-op mitral valve replacement. We have also done direct implantation of the SAPIEN 3 valve in the mitral valve position in combined surgery. So rather than actually replace the valve surgically, you can just open the heart. When you do it, you can directly implant the SAPIEN 3 valve. Then you do your tricuspid repair or other concomitant surgery. It really simplifies the procedure. Here's a review article looking at TMVR for failed biprosthetic prosthetic valve that we recently seen. And you can see this is an example case, 59-year-old female. Unfortunately, the patient had right thoracotomy mitral valve replacement that went very badly. You can see right phrenic nerve injury, tracheostomy, ischemic bowel, required resection and colostomy, resulting her in a COPD and home oxygen, and also other medical issues. You can see here normal ejection fraction, moderate severe pulmonary hypertension with severe MR, but also severe MS as well, mean greater than 15. You can see here the 27 Paramount valve, the LVOT measurement after the neo LVOT calculation, I'll show you in a moment, was significantly reduced actually in this particular patient with a neo LVOT index that I measure around 0.88. So the question is, in this question, with a high risk of LVOT obstruction, you can see in the transthoracic echo here, should it be done, and do we need to worry about anything else that could happen? You can use the valve in valve app to decide what valve to use. You can see this is a borderline between 26 and 29 SAPIEN 3 valve. And in this case, we decided to use a 26 SAPIEN 3 valve to reduce the risk of LVOT obstruction, but also allow the valve to expand more to reduce the transmitral gradient. You can see the new LVOT measurement up top that was quite reduced. So we certainly need to prepare for LVOT obstruction. So what we would have in the room is either impeller or cardiopulmonary bypass machine, and we'll be ready to do septal alcohol ablation if we need to reduce the LVOT gradient. Obviously, the anatomy has to be favorable for septal ablation. You can see at this particular case, the valve was a bit challenging to be deployed in terms of optimal position. Normally, you would do the transeptal more inferiorly and also more posteriorly. But you can see in this case, the patient had right thoracotomy mitral valve replacement, and actually the septum was very scarred. The surgeon did a transeptal approach, so it's very difficult to cross. And so we had to actually navigate around the atrium to get to the valve and deploy it that way. So there was actually a remarkable improvement. You can see here the PA pressure went from 90 to 60, the V wave went from 60 to 25. We actually closed the ASD because of the problem with the septal crossing. And you can see here with the gold cardioform device, the patient actually went home in about a week off home oxygen and the very acceptable mitral gradient and a small neo LVOT, but the LVOT gradient was not significant. You can see here as predicted in our CT analysis, there's not much room between the stent frame and the septum. You can see the septum was very thin, so there was really no way to do a septal ablation, even if we go and get in trouble. And you can see the post-CT here, certainly very close, but maybe because the surgical mitral valve is stenotic, the leaflet do not go all the way down to the commissural post, so maybe that way it avoided the LVOT obstruction. And here's some CT analysis showing the frame is quite well expanded, certainly a little bit constrained the mid portion, but the outflow was quite well. You can see again here in terms of the different views. You can see again here the LVOT. But what's important to look at is the valve anatomy. So you need to know the leaflet, design whether it's porcine or bovine, the stent frame, the sewing ring, and the stent ID versus true ID, because the label size is often larger than the actual ID itself. So the internal diameter of the surgical valve are those the most relevant. We don't really care about the label size, and these diameters are smaller because you don't want the implant a valve that's too big and risk gradient. So here's how you size, as I mentioned before, on CT scan. But there are some caveats. You have motion artifact, booming artifact, there's some contrast washout. You have to make sure they're in the same plane so you don't end up having artifact from tracing the valve in a nonlinear fashion. And finally, you have to make sure some valves have no visible landmarks, such as a mosaic valve and a St. Jude epic valve. So you have to be very careful about implanting an optimal position. So the sizing, you can also do it by TEE. You can see this is a TEE on the on-force view. The caveat, of course, is whether you use 2D or 3T, and it can be depending on the imager. There's also maybe booming artifact, and you can risk underestimating the size of the valve. So the app is the easy way to do it, as I mentioned before, courtesy of Dr. Bapat. And you can see here, it's not that easy though. You can see that different valve that looks very differently. So you have to position each the SAPIEN 3 valve individually based on the type of valve that you see. The Valve in Mount app is very simple. It's available to download free on Android and iPhone. You can see here, you can pick different surgical valve, different size, what the ID, and then the recommendation on the size of the valve and the type of the valve. The positioning is also illustrated here. You can see here the SAPIEN 3 valve. You want to implant around 90-10, 98 ventricular, 10 atrial to allow the flaring and the reduced risk of migration or embolization. You can see here because of the atrial foreshortening of the SAPIEN 3 valve. And of course, you want to discuss whether you want oversize, true size, or overexpand and undersize. And you want to see whether there's stenosis or regurgitation. If it's stenosis, there'll be more bulky tissue leaflet involved. So you should be able to true size and overexpand. Versus if it's primary regurgitation, the leaflets are more compliant and not as thick. So you have to make sure you don't run into situation of undersizing and risk of migration embolization. So here's the risk of embolization. This is an XT valve. You can see transapically deployed. Okay, so you can see here, initially it might look okay, but the valve is undersized And you can see here, in this next case, certainly not what you want to deal with, and you can certainly have a catastrophic result. And then this is another issue where you have the parallel stent deployment, and you can see the valve can actually migrate with time. Now, this is not as common now with the SAPIEN 3 valve because it's taller frame, but certainly that was an issue early on with the XT valve. Now, the reason why this happened because the higher closing pressure in the ventricle in this mitral position, if this happens and you do not flare the ventricular side, you can ultimately potentially migrate and you can see cause a embolization, versus if you do a more conical deployment with the flaring of the ventricular side, you'll be safer. Orientation in terms of flaring may matter. So you can see here in terms of the deployment, if you have the commissural post away from the commissural post from the surgical valve, you might be able to better flare outward as well because there's no constraint against the commissural post. LVOT assessment, as I mentioned before, is very important in terms of calculating the risk of LVOT obstruction. There are some risk factors such as the aortic mitral angle, septal hypertrophy, the long anterior leaflet, which is now the surgical valve leaflet, how much does the valve protrude in LVOT, and of course the mitral annulus, which is less important in this case of valve-in-valve. There are 3 ways to deploy the valve-in-valve. Most of them are now done transeptally because of the safety and early discharge and recovery among these patients. This is an excellent paper by Mario Guerrero and co-authors looking at step-by-step how to do the mitral valve-in-valve. There are many steps, but here is a nice summary of the equipment and what to do. In these cases, it's very reproducible, just like a TAVR. Transeptal is key in TMVR and valve-in-valve. You can see, unlike a mitral clip, which is more superior, we aim for more inferior to allow you to have a better alignment with the surgical valve. You can see here. So you do not want to do what's on the left side. You want to do what's on the right side, where it's more inferior on the bicaval view while you maintain being superior. The distance to puncture typically is 2.5 to 4 centimeters. You do not need 4 to 4.5 like the mitral clip, because you want to have a short distance to travel between the septum and the surgical valve. Just like here, you can see the optimal valve trajectory, like what you see here into the left ventricle, and here you can see an example of balloon septostomy, and you want to see the trajectory very smooth curve in this fashion. So other issue to consider. So if you have the balloon septostomy to allow the valve to cross, typically use a 10 millimeter balloon for the 23-26 valve, and about 12 to 14 millimeter balloon for the 29 valve. You have to check the orientation. It should be integrated like the transapical fashion. The residual ASD, we typically like to close on the way out because of the residual impact on the right side. And anticoagulation, we like to give Coumadin for 3 months, and then baby aspirin as well. However, there are some concerns about residual stenosis. Post-mitral valve-in-valve, you can see it depends on the internal surgical diameter. The post gradient can be as high as a 10, which can be a concern for functional stenosis, especially in a smaller group. You can hear where mean gradient all the way up to even in the teens. And you can see here again the post-procedural gradient. This is the vivid registry. Usually is the smaller surgical valve. Here's a paper looking at the outcomes of valve-in-valve versus valve-in-ring. You can see a valve-in-valve in terms of risk of thrombosis. You can see it's higher than valve-in-ring, and certainly can persist to very late as well. And if you look at the risk of thrombosis and anticoagulation, if you do not anticoagulate, you're at much higher risk of leaflet thrombosis in valve-in-valve. Here's the 1-year outcomes on the TVT registry in the United States that was presented at TCT recently. You can see here most of the cases done are now transeptal, over 1,300 cases, which is transapical. You can see the volume now has gone up to over 600, and however, the volume per site still remains relatively low. And you can see here the STS score is quite high, 11%, certainly very high risk of re-op. And the floral time is quite short. You can see here device embolization is very rare, LVOT obstruction is very rare, and conversion to surgery is very rare, especially in the transeptal group. You can see here the 1-year mortality. Transeptal is certainly better than transapical on the right side of the screen, 15% versus 21%. And you can see again here the all-cause mortality is also lower with the transeptal platform and also cardiovascular mortality. The gradient is similar. And you can see here the only predictive variable for 1-year all-cause mortality, one of the most important one is transeptal approach, which is protective. You can see here as well that with transeptal being more popular, the 30-day mortality has also fallen as well since the introduction of this technology and this technique in the United States. So in summary, mitral valve in valve is preferable to reduce surgery, and I think now is the standard of care with favorable anatomy, and I think transeptal approach is the way to go. And you can see here, in summary, direct mitral valve in valve can also be done if it's combined with other surgical procedures. It can simplify the complex operation. Pre-case planning is critical to evaluate the valve size and LVOT obstruction risk. Thanks very much.
Thanks a lot, Dr. Gilbert.